We will introduce for this next panel Debbie Dalton, Hospital CMO VP of Medical Affairs, past Chair Georgia Composite Medical, and Press-elect Medical Association of Georgia. Michelle Nuss, Founding Dean, University of Georgia School of Medicine. Geeta Swami, Associate Vice President for Research, Vice Dean of the Duke University School of Medicine. And Sandra Wong, Dean Emory University School of Medicine.
Well, good morning, everyone. Thank you all so much for being here. We've got a great panelist here, some distinguished women who are deans of medical schools, and we're going to be talking about the future of academic medicine. So we'll go ahead and start and talk about the physician shortage issue that we have. It's nationwide, of course, but we're going to talk about what's going on in individual states and what medical schools are doing to help mitigate the physician shortage issue. Would anyone like to start?
Thanks, Debbie. So go by Shelley, but nice to be here. And, you know, I think Debbie's hitting on a really important topic, and that is for so long they thought there was no shortage, believe it or not, of physicians, and then there was an about face and said, no, we've calculated wrong. We actually do need more physicians. And so that push started in the mid-2000s, grow more campuses, grow more doctors, grow more residents, and that's kind of where we are. And so a lot of things have happened. The campus that I overlead now was one of those outshoots to try and address the shortage. So multiple pipelines need to happen to address the shortage. Georgia is ranked 40th in most metrics in the number of doctors, the number of resident physicians, and public medical students, as well as private and public medical students. So I think it's a challenge, and I'll let my other folks address it, but got to address the pipeline problems in not only medical student enrollment, but also in graduate medical education, and we can circle back to that.
Yeah, I totally agree with Shelley's comments. In many ways, it is a very long pathway issue that we need to deal with. I know many of you probably grapple with it on a more regular basis because we actually have a lot of access problems across the board in our state, primary care and specialty care. And we highlighted a little bit graduate medical education. We also, and hopefully Shelley will talk a little bit about this with new medical schools in our state, but really an opportunity to increase how we train for undergraduate medical education. But I actually think the pathway issue needs to go further back than that. And that stems back to high school students and college students, and possibly even farther back than that, to encourage our young learners to think about careers in healthcare. And it's not just about physicians. I think it actually includes all clinicians and those of us who need care across the board. And we have a lot of staffing problems.
Yeah, one thing that, nice to be with you all today, and I will say that as the odd person out, not from a Georgia school, I do have Georgia roots, was born in Griffin, Georgia, and go all the way back from high school days. But one of the things we're doing in Durham, in North Carolina, where Durham is actually titled the City of Medicine, but that focus has been really on that medical school and thinking to the point that Sandra made about how do we think about this earlier to really develop that pipeline and that pathway is something we're calling the Durham Early School with Bloomberg Philanthropies to invest in a high school pathway to healthcare where individuals can have both a high school diploma and an associate's degree and actually interact, right, get used to the healthcare system, feel like they have a place, that they have a sense of belonging, because I think that's another aspect. It can't just be about training for a job and then say go look for a job and make it on your own, right? So how do we really make people feel like they're part of the community as well? And I know that that's a lot of what you're probably doing in the development in Athens as well.
Right. So one of the things that happened this past year in February that probably needed to happen a while ago, which was do what Florida, Texas, and California and many other states are doing, which is add an additional independently accredited medical school. And so the University of Georgia will be building out an independently accredited med school, and will add to that bottom line of the physician pipeline, and then ramp up from 60 to 120. So we've been educating students in Athens in partnership with the Medical College of Georgia for 14 years. So we're not new in this business, but how do you evolve this curriculum, I think, to be forward-facing, innovative, active, and engaging for our learners, but integrating the technology that's out there, that high-tech, high-touch aspect. So this will be a huge thing for the state, I think, to impact actually that medical student part, but we've got to build up that residency program stuff as well.
So when you think about starting medical school, so students come in all shapes and sizes and all different forms and all different backgrounds. So how do you choose medical students who are going to come to your medical school so that you can ensure their success to complete medical school and finally go off to residency and complete their residency as well, so that you can build that pipeline that you're talking about?
This is a panel discussion. We don't have a lot of slides, but it wouldn't come as too much of a surprise to any of you that if we were to show you some statistics, you would see that we get an extraordinarily high number of applications for each available slot, not just here in Georgia, but across the United States. So it's not a shortage of applicants or potential candidates. We just need more slots. And those training slots are really valuable, both on a UME and a GME level. So in some ways, we have a wealth of really terrific applicants for every slot. And I actually think that when you're putting together a class, there's a lot that goes into it. We want to train people who will be able to serve our communities. We want to train people who look like our patients. And we want to train people who bring in different talents so that we have a diverse workforce. That workforce needs to encompass primary care, specialty care, research and innovation, and educators who will train the next generation. So I think there's a lot of different ways that we look at that. I welcome other perspectives on that, but it really is, Debbie, it's such a tough question to answer, but we really do need to focus on what our classes look like and what they will go out and do.
I mean, I think back to when we all trained to what training looks like today. You know, the young people today demand a lot more in ways that are thinking much more about their life and well-being on a day-to-day basis. You know, duty hours, we all were probably in that mode where we're like, this is ridiculous. They just have to suck it up and do it. And now you realize that that wasn't right. We need to do better, but where do we rebalance that? And I think also exposing our trainees to all aspects of healthcare, right? If you're only in an ivory tower of subspecialization, then coming out and saying I should go into primary care, there's been nothing along the way that is telling them that that's a good pathway. So how do we make sure that we are connecting them all across to every aspect of healthcare so they can see all the avenues out there and see the pluses and minuses and what they might choose from. You know, I did my medical training in Chapel Hill, and then we sent students out to everywhere. We went out to, rural clinics. We would stay there for 2 weeks, learn, live with members of the community, understand what the impact that we had on that community was. And I think we have to get back to some of that and figure out the ways to do that as well.
So I'll just add, most med schools are doing what we call holistic admissions processes now. And we do that at MCG. We're going to be doing it at the UGA School of Medicine. And that's how do you identify that individual that has all the attributes that we're really challenged to try and figure out. What is every graduate of a medical school, skill-wise, attitude, others, do they need to have to be a successful physician? In my personal opinion, the home run doctor is the one that has that humanistic, compassionate, empathic bedside manner. The technology is bearing down on that. The corporatization of medicine is pushing that aside. So how do we keep our students grounded in that process to bring the joy of the medicine when so many competing things? So I think the holistic process does try and identify that. At UGA, we also have the Archway partnership. Archways under Public Service and Outreach. They're in all 159 counties. We're going to try and use that backbone to deploy students like you mentioned, Geeta and Sandra, out into the rural areas. Emory is sending surgery residents now to Moultrie every month, exposing students and residents to that area. You hope you get them coming back to that area. And then where are you recruiting students from across the state? And what's your balance of gender? You know, women now outnumber men in enrollment as well as applicants. That happened somewhere pre-COVID, and it's not going to change. It's going to keep growing. And so, you know, there will be more medicine, more physicians that will be women coming out. So.
Great. So all three of you have touched on access to care and you've touched on curriculum. Let's talk about curriculum. That probably didn't change a whole lot during the 1900s, I think, and during now the 2000s. We're seeing a whole lot variation in how students are taught and what we're exposing them to. So maybe each of you can talk to us about how your medical schools are looking at changing the curriculum to meet the needs of our future patients, and of course patients of today, but future patients, because we need to prepare them for the future.
Yeah, we're actually in the midst of an education transformation. It sounds really great. It's a lot of work, as we're talking about here. I guess a few of the points have already been made by Debbie. You know, we have to continually refine our curriculum to keep up with the vast amount of knowledge. And we're increasingly becoming high-tech, which also means we have to be high-touch. We have to be able to teach everybody how to use technology better. And in the midst of that, how to actually have higher touch with our patients. That's going to be something that we really focus on. You know, we can talk a little bit more about some of the technology, electronic medical records, big data, AI. All of those things are new to every school's curriculum, and we need to keep up with it. Otherwise, it's left to chance in many ways. I mean, I know I learned the electronic medical record with at-elbow support. Good luck. And during the pandemic, we learned how to do telehealth. Good luck. Necessity was the mother of invention, so the saying goes. But we should have a way to teach it better, because we can innovate better if we understand it better.
I think in addition to that, with the changing environment, that we really have to make sure we're teaching critical thinking skills, because that, at the end of the day, gone are the textbooks, right? You can find anything at your fingertips that you want to know, but how can someone make sure what they're assessing is accurate? That's the right source of information. That's the right information they should be seeking because of the patient that's in front of them. You know, how are they critically thinking about approaching patients and their families? What is the situation in front of them? How do we teach shared decision making? It's a great phrase. I like it in theory, but when you read it in guidelines, I'm not really sure that I know how to implement that. So while we clearly have to do all of the work in transformation, I think that's a theme across many medical schools now, that Duke has done that as well in the curriculum redesign. But at the same time, we can't forget, how do we actually still then get back to connecting with our patients, connecting with our staff, connecting with the entire system? And if we just teach the content, we're going to miss that because of these phones we have and the disconnect we have between actually doing a lot of things in person. And the duty hours is a real thing. We still have not figured out how to make up for the lost time that was gained when people were working 100 hours a week. We kept the residency training the same number of years, but not made up for those gaps. So I think those are some of the things that we still have to address.
Yeah, I think the other transition in education is, and I'm sure all schools are doing this, or were actually told they had to do it by the accrediting body, is it must be engaging in active learning. So the student must be involved in the process of learning. The old saying, death by PowerPoint, which is the way I went to med school, probably all of you, where we were sitting and being talked at with a PowerPoint, which we're hopefully not doing today with you, and that's why. But how do you get the students to engage in the process of learning? And so I've charged our faculty that there should be no session where a faculty is just talking out. There is prep work before, and then real application of patient cases through small group and large group sessions. and engaging everybody in that process. One of the unique things we do in Athens is that we partner a scientist, a PhD, we're all kind of scientists, I get that, but a PhD with an MD in almost every aspect of every interaction that they have in their learning process. And so through their small group, we're not there to be a content expert, but facilitate the student learning, self-directed learning, identifying your own problems that you see, and then researching and bringing those back. It can't be Dr. Google. We've got to have evidence-based places that we look, and anything they do, they have to actually cite where they're actually getting that information from, because as you know, AI is only as good as the information in the system that it's pulling out from. And so, you know, they have to be sure they're looking in the right resources. We also have embedded our librarians into the curriculum, because, right, textbooks that weigh 40 pounds exist. That's not how they are anymore. They're all online. And so, and then multiple databases. How do you teach a student where to look for the answer for the clinical question? So just a lot of changing things that we're doing over in Athens.
Can each of you talk about a little bit more about technology or AI, especially since everybody's talking about AI, and how that we feel that might impact the training and the knowledge base of the medical students, and eventually how they go out and practice. I know it's probably a little nebulous because it's still pretty new relatively for medicine and in incorporating it into the curriculum, but can you each just comment a little bit about how technology and AI might impact medical students?
Yeah, if I may, maybe I'll start before touching upon AI. Certainly, I'm not an expert. But I think if we think about telehealth writ large, just bigger picture telehealth, telemedicine, there's so much opportunity that we can leverage those tools. We've talked about rural populations. I think there's a lot of opportunity there. I think we can use telemedicine for more remote monitoring, kind of taking care of patients at home better. So there's a lot of different ways that we can apply that to actually extend the services that we provide in the clinic or in the hospital. And that is yet to be tapped. And I think there's a lot of opportunity for growth there. In terms of AI technologies, I also think that we have a long ways to go. We do have to mind it because, as Shelley indicated, it's only as good as kind of the data that we provide for it. I think we're getting smarter and smarter. It's actually amazing how much progress has been made in just a few short years. And I think in many ways, the better we're able to use it, the better we're able to actually be physicians and take care of patients. There's probably some resistance to that for some of you who maybe are on the sharper end of the stick on that. It is scary in some ways to think about the applications and the amount of trust that you have to put into the applications and what may actually need some double checks because maybe we're not quite there. So there's a lot in that, but unless we actually delve in and invest resources and research into that space, we won't get there.
Yeah, I mean, I think, there has to be a phrase that we've used a lot about whether it's trustworthy. How do we have trustworthy AI tools and resources available to us? And I think it goes into in the curriculum space, I think it gets back to thinking about how we are, again, guiding our trainees on when are the best times to use it, when are times that maybe it's not so great to use it. Do you know what is in the background of this algorithm or tool that you're using, or is it just that you're going online and using something that pops up, which gets back to the Ask Google sort of situation. So I think it is amazing how much has happened already, and also amazing how much we're still at the beginning, because I think everyone looks at it as the answer for everything, and then you go and look at it and you're like, well, did this really save me time? Did this really provide anything more than what I was already going to do for it? I think we're just at the fledgling sort of state. I think, though, we're going to see AI tools probably help us much more in process and delivery of care and access situations, right? Because we can trust it to say, hey, there's an appointment that just opened up. That's a real appointment slot that opened up. Can we find someone on our waiting list? How many people have had that? You get put on a waiting list and you know you're never going to get called, right, for that appointment, because by the time they call you, there's no way for you to get there either, right? But wouldn't it be great if your system just identifies it, finds someone who said that was a preferable time that they wanted, right? But all of those things we need to put in there. So I think we're going to see that happen much quicker, I think, than actually delivering care. Although self-monitoring or home monitoring is probably the next step, because it would identify things that could send out alerts, although best practice alerts are mind-numbing at times, right, in our electronic health records as well. So
I'll just add to Geeta too, for machine learning and other things too, overreading a breast mammogram, and because it's learning, it's got information, and then sending things back to then a human radiologist, right, to confirm. And look, my opinion is doctors will not be replaced by robots or AI or machine learning. That's just not going to happen. I don't think it's what anyone in this room would want to happen. But there are applications in healthcare, I think, that are out there. I think it's growing rapidly. It does need to be moderated and managed, I think, but our students are using it. They're on Browns, they're on an iPad, they're looking for clinical answers to quick questions at the bedside. So there are ways, how do you access that through a phone and otherwise, and how does it impact the patient's care directly so that they're getting the best top quality evidence-based care in the moment. And so there are definite things that technology will help with, but how do you train a student, back to the curriculum, to do that more effectively? And so those are the challenges that I think all of us that are in academic medicine are faced every day, and how do you do that? So we're still learning too. We listen to our students and our residents a lot. They teach us about this. Well, Dr. Nuss, what about this? There's those moments, so they come up with things. It's kind of interesting.
I love that example of helping with mammography readings. It doesn't replace it. I don't think, we may not ever be there, but it doesn't replace it. But one example, since I mentioned high tech, high touch, is there's ambient listening to help with the electronic medical record. And so all of us, I'll include myself in that, you've been in a patient visit, and everybody's so busy charting, and you're kind of looking at the computer and you're charting, and you're sort of talking to the patient who's sitting kind of right there. But with ambient listening, it's sort of like having a scribe, an AI scribe. So you can actually have the conversation with the patient, and then at the end of the encounter, a note sort of gets generated. And they're pretty good. And we did a pilot, and there was a high level of satisfaction with that. So that's just a great example of how we can actually use those tools, along with radiology. Pathology is also there.
Right. I mean, I think in diagnostics, like if you have some sort of bacterial culture, it comes up with a result, comes up with the sensitivities, it can feed you, right, what is the right treatment or what is the recommended treatment, but not go execute, right? Feed it to you to see, give you all that information in one space rather than you have to click here, you have to click here, you have to go look at the allergies. If it puts all that information for you right there to look at, you still have the human being making the decision and the judgment. So I think those are the kinds of things that we're going to see come forward sooner.
Great. So yeah, high tech is great, but high tech doesn't deliver babies. High tech doesn't suture either. So you got to have the hands-on training as well too. So sticking with low tech, I'm going to consider it low tech. What else do you anticipate changing in the curriculum in medical schools that might help gear a medical student more towards what they might be interested in? Let's say a medical student is interested in becoming an OBGYN or an emergency physician or just any specialty, but can you change the curriculum in medical school or fast track certain paths for medical students to make that more geared towards what they're interested in the future?
So I think the answer is yes. I'm not sure that we've exactly figured it out yet. So as an OBGYN, I can say, right, and we've talked for many years, right, I'm a high-risk obstetrician. I knew I wanted to do that about halfway through my residency. Had classmates who wanted to do gynecologic oncology. They knew that pretty early. So why do we still do all the same things across the board, right, to do that? But back to your point about not having enough slots, we need to have enough people that we can move individuals around in that space, right? Because if I move someone into one pathway, it means the other things they were going to do are either uncovered or I have to change someone else, right, to match it. So how do we have enough built-in redundancy or leeway to be able to do that? I think that will help us, though, on the pathway to getting folks to the areas they want to focus in sooner. Similarly, if you're in a internal medicine pathway and you're in your third year and doing yet again another critical care unit month, and your plan is to be in primary care and not be attending critical care, do you need exposure and understanding? Absolutely. But do you need 8 unit months in that time, right? So these are the things we have to be thinking about, but at the same time, not offset the needs of the care that we're delivering too. So I think we have to be smarter about this and figure out where to flex slots back and forth, but it takes work.
Yeah, I'll just add, I think finding good mentors, so one of the number one reasons why students choose a specialty is not that it's just a good fit for them, whether you kind of put them in a surgical or non-surgical way, but finding an amazing role model and mentor, and that is one of the top reasons why students of today will select a certain specialty. And so we, again, starting earlier, finding physicians that are willing to provide that mentorship on and off the campus really, I think, is helpful. And I don't know if Emory's doing that or not.
Gosh, I think that's such a great point, and I'll expand mentors to just exposure. And so that's why we talked about this a little bit. That's why I think the rotations at different sites are so important. You wouldn't have an idea that you might be interested in practicing in a rural setting unless you're from a rural community or you rotated in a setting like that. And sometimes that exposure makes all the difference. And that's true with specialties. That's why we have rotations. But I dare say we don't have rotations in every specialty. And so that's where the mentorship comes in. That's where the opportunity for exposure comes in. Because in many ways, if you don't ever get exposed to it, if you don't ever see it, it's not on your radar screen. And I think in many ways we can encourage more primary care if we have that exposure to it. And we need it, period. So I think that's actually really important. Location, specialties, mentors, and that's something we have to be a little bit more deliberate about and more intentional about it, because right now I think a lot of it is as it happens.
Yeah, it's by luck that they maybe meet someone in the hallway, but I think finding a good fit with a mentor too is important. Who is it? If it's a male one, maybe they want a woman, maybe they don't, but how do you mix that in and how do you create programs, I think, early on in med school where you're trying to pair them up with more senior students and residents, but also those that have been out in practice, because it's different.
Yeah, I think you said it best, and I think back to how I chose where I went, and it was because I met someone that I clicked with, and mentoring, but it was also someone who I wanted to emulate, right? I wanted to be like them. I really liked their approach. I liked what they did. I liked how they lived their life, and I think that's another aspect, is that as healthcare providers, the way we interact with each other, the way that our tone is, our mood, our happiness or not with our jobs does actually impact our trainees and what they see, right? If they see people in a certain field are always complaining and upset about something and feel undervalued, underrepresented, why would anyone want to do that field, right, or specialty? Now, I don't mean that, so we have to figure out, right, what is it about our jobs and our professions and the areas we've chosen that we need to also make better, because there's no reason that anyone's going to want to emulate a person who's dissatisfied with their position.
Yeah, and since this panel is really around academic medicine, I will say that's probably true if we're looking to train investigators. Critical exposure to research opportunities makes people interested. It gets people passionate about discovery, and that is really an important component of what we do in our training pathways. So many of our young people who are interested in education is largely because they had such great educators and exposure to people who so cared about their teaching and their learning, that we have a whole generation of people who will change the way we teach and learn.
Excellent. So let's switch gears to access to care. I'm sure many of us have had issues with access to care just day to day with our family members as well. So virtual medicine certainly has helped quite a bit in that realm. But I know in the state of Georgia, there are several counties that have 0 doctors. There are several counties that don't have a surgeon, several counties that don't have an emergency physician, several counties that don't even have a pediatrician. And I'd like to hear what your medical schools are thinking about, and what I know some of your schools have already done, but talk about what you have already done and what you think you can do in the future to increase and improve access to care for patients.
Well, I call them healthcare deserts. I know Geeta has a different idea. It's not healthcare desserts, but
Right.
listen, there's so many places south of 20, right, and even above. 123 counties are rural, I think, in the state of 159. And I think we've hit on some of this. Getting students from those areas, getting back to those areas are very, very important, because if they can't see it, they can't imagine what it's like to be there. I do think this generation is a little more mobile maybe than others, and many leave the state for residency, but we want them to come back. One metric Georgia actually does do well, because we're about 40th and everything else, is we're ranked about 16th in terms of retention of a resident. If they do residency in Georgia, about a 50% chance of staying. If they do undergrad med ed, so at any of the med schools, and residency, we're at 72%. If you back it into high school, which we've talked about, it's over an 82% chance that student, when they finish, will actually stay in the state and practice. So that was one of the angles that the USG did, is how do we get some new teaching hospitals in more strategic areas? And so I'll just say we put up around 1,000 new residency slots in the state since 2013. Which is amazing, and we're supporting those now, but at least 9 or 10 new teaching hospitals. And so getting more students, more residents, and I think in strategic locations can help.
Yeah, I think it obviously starts with workforce. But I think from a medical school, academic medical centers, hospitals, health systems perspective, we can do better coordinating care. Because sometimes it is about delivering their care locally, but oftentimes it's about traveling for care. And when that's needed, you have to coordinate it better. We have to be able to talk to each other better. The electronic medical record does a lot for that. But in terms of coordinating, and I'm a surgeon, so when you coordinate the kind of care for pre-op, post-op, that sort of thing, it really needs to be done better. And I think with technology, we're very well positioned to do that. But at the end of the day, it comes down to relationships. Can we actually just talk to each other about a patient? Can we feel good about referring patients? And, kind of compete to collaborate, if you will, because I think a lot of times people see it that way. But it really shouldn't be. It should be about how do we actually just coordinate the care for the patient. And sometimes it has to be across systems.
I mean, I think we also still have to be smarter where we are. As a profession, we have a long-standing approach of being gatekeepers, right? We just think, we can't get the right patient in the right place if we let them schedule. I mean, how many people schedule their physician visits online versus scheduling your air travel or your appointment for your hair appointment? Anything you can do now online, and yet we still struggle with these kinds of things in healthcare because we just think that people won't do the right thing, or they don't have the right knowledge, or we somehow can't set it up. We have to get to, I like to say, we need to get the right patient to the right place at the right time. So how do we do that? And where do they want to be seen, and when? How many things are people doing after business hours? The days of 9 to 4 for your appointment slots is really kind of silly. This isn't how any other profession is functioning, right? That we think about where are people. I used to say when I was a resident in training, I said, if we could have a child care facility as well as the dentist's office and some other thing right here outside of our prenatal clinic, we could get all these things done, right? We kind of did that in the old days where we said multi-specialty practices, except we still make them check in at every desk along the way, and insurance has to be checked every single time. And, I won't talk to you because I'm seeing that patient at 2 and you're seeing that patient at 10, and between that, we're both busy. So how do we coordinate all those things, right? We have to somehow figure out how to do that better. And that's just within the resources that we have, which still has to absolutely be able to improve access at the end of the day, which I'm certain that it can.
Yeah, and I'll just build on that, partnerships across the state of Georgia, not just in our major hubs, but how do you create collaborative partnerships with larger health systems, with smaller health systems out in the community to provide that better care. So there has to be a way that we all are working together. I always say we can compete on business, but in education, we've got to work together. We've got to create partnerships across. And you know, how many of you have waited 4 months to see a rheumatologist, 5 months to get in to see an endocrinologist, have a rash and you can't see a dermatologist quickly? These are real problems, and as you said, when it's today, you need to be able to get in to see somebody, and how does that happen? And so we're not doing that good enough. I think there's definitely work to be done on that, maybe through machine learning and AI and others, but we have got to do better because we all have problems, and you want to see that doctor when you want to see them.
Excellent. All right, so I'm going to switch gears again. Let's talk about research and funding GME programs. This is the way that medical students learn, and even people who are not in medical school or are going to become a physician, there are lots of people in the healthcare field who are involved in research in the healthcare field, and we have to be able to work together to improve our innovations and our care for patients. So let's talk about research programs and how we can fund those programs better, and eventually talk about funding GME programs as well.
Yeah, so maybe I'll start because that's certainly my area of expertise is in research aspects at Duke University. And I think one of the things that's important for all the things we talked about is where we do research, how we describe it, what's the perception of it is really important, because traditionally, we've looked at the majority of research in healthcare or advancing health as being NIH funded. We have had I would say, an interesting and very, at times, strained relationship with industry, between industry and academia, with the idea of research that the perspective is that if you're in academia, industry has their own reasons, and I would say that is, I would argue should be completely debunked. Everyone is actually trying to advance health. Do we have profit and not-profit differences? Yes, but that doesn't mean that we're opposing. So I think keeping research and this idea it's got to be just in the academic center is actually limiting to our patients, limiting to our providers, limiting to an understanding and trust in what research is and why it's important. Additionally, if we only have research done in a tertiary care setting, it means the results are often not generalizable to every other person out there. So I think we have to think about how research gets integrated into the delivery of healthcare, just like we've been talking about education getting integrated into the delivery of healthcare. And the funding aspects are another ball game, but I'll stop there for a second and we can see if others have something else.
Well, I can jump off the funding aspect of it. I think, Debbie, you kind of set us up to have that discussion. I think in many ways, we, in the current kind of environment, the current way that we set it up, we really don't have enough money to cover our research mission. And those dollars have to come from somewhere else. And so it becomes really a question of research priorities and what we expect when we discover something or innovate something. Because to me, it's about getting it out in front of the patients. It's about the implementation arm of it. And I think we need to pay attention for the whole spectrum from basic and translational science out to population health. And it's a whole spectrum. And I think in order to really appreciate the investment in research, we need to kind of get everything from that phase 0 all the way out to kind of the phase 4, if you will. But the reality is there's not enough funding from any of these agencies, federal and otherwise, to cover our costs of doing research. So then it becomes, where do we get the money from, and how do we prioritize how we spend the money?
I think one of the things you'd said before in learning from what happened during COVID, right? I think that the one other silver lining to that is what we call the decentralized trials. So initially it had been that you do a clinical trial or clinical study, everything happens right here. I have to make sure you do it exactly the way I said it, so I've got to see you here in the office doing that. And we know that's not really the case, right? I can FedEx you a product or a package. I can order a lab draw that you could go to a lab and leave, a drop and go sort of place that comes back to my central testing. So we we have to be implementing these things, again, in those ways where we don't have to have someone drive 3 hours to come for a study visit every month, because that's just not realistic to happen. It will also, I think, cut down on some of the costs, because a lot of the cost has to do with everything being in the costly location as well, and can we move that out into other ways?
And I'll just, add one caveat. With the new school in Athens at UGA, we are going to build out that research mission right from the very beginning. And I think when we were chatting before, we think this is critical for the School of Medicine, but I think it's also critical for our students to learn that discovery and innovation and scholarship is part of what we do as physicians as well. And when we do have something that we've learned, it's kind of our job and duty that we should publish that and get it out there so that everyone can learn from it. So I think the research mission, integrating research curriculum, it can't be real heavy. Right now we're trying to figure out what to take out of curriculum every time we want to put something in, because there's only so many hours in the week we're actually allowed to have the students in a classroom. So, but it's a challenge, but I think that's the right way forward. I mean, discovery and innovation has to be part of what we are doing as well as physicians.
Great. Well, we only have a few more minutes left, so what I'd like to touch on is if you can think about all the things we talked about here on the stage, and how does that fall in step with your school's mission, and how you're going to push forward that mission for the future. Anybody want to start? Sandra?
Yeah, thank you. Well, when we talk about academic medicine, we very commonly talk about the triple mission, right? Research, education, and clinical care. I always add a fourth, and you could probably keep going, add 5, add 6. But I think the fourth is really about community and how we actually are good stewards of everything that we do to bring everything to the level of the population, to our communities. None of that other stuff matters unless you actually have that core pillar. So I think in many ways it's about rethinking and reframing our missions and how we actually drive value in what we do.
Yeah, to that point, we've agreed with that approach as well. Like, I think about our pathway to promotion at Duke for physicians and faculty, and advocacy is a component. And talk about what you've done in that space. Often that's in the community space, or if it is in serving on committees, national guidelines, society type things that you might be doing that are not, that, let's be frank, it is taking up your time, that you are not getting compensated for, you are not seeing patients during that time. So how do we, make sure that that is part of our mission, because then it should, and the way we do that is by valuing it from that perspective. I think the other thing I'd like to just add is we've been talking a lot about the viewpoints here from academic medicine, meaning schools of medicine. And we think really have to be thinking how we are, again, holistically looking at healthcare from all the other aspects and professions of healthcare. Again, I think we learned during COVID, at least for us, we had to hire so many individuals through locums and travelers to support the nursing workload and other folks in the first line space. But why do we isolate medical training from nursing training, from physician assistant training to nurse practitioner training to certified nurse midwives? Yes, there should be dedicated schools and curriculums, but we also need to be thinking about where we are integrating and overlapping with those as well. So I think that's going to be in our future, to really make sure that we can cover all aspects of what we need for patient access and delivery.
Yeah, and I'll just say the service mission, the community engagement, very, very big, I think, for our learners. And one of our missions is to, improve the access to care, produce excellent physicians, but increase that access to care that we've talked about. So, all of that is integrated, you hope, from the beginning, where you're starting to work with the students, exposing them to the community. I think getting them to understand how much advocacy is important, because, I think doctors are very busy. They're underwater with a lot of paperwork and bureaucracy, and we forget to be on those quality committees, to be out there advocating for things that we know are going to be better for our physicians of today. But, we developed an Athens free clinic. We now partner with Clark County. We're giving free care through school-based clinics in Clark County for people that have never had access to care. So all the teachers in Clark County can now come. We're providing that through a population health kind of curriculum. The students are all embedded in this, so you hope it creates physicians that then want to give back to their communities later in whatever way that they can. So, but if you don't put that in early, they just kind of forget about it, because it's pretty busy out there being a doctor today, guys. I'm not going to lie to you. It's a lot of things coming at us, and, but we've got to do better. We all can do better every day. So anyway, this has been a delight actually to be here.
And thank you, ladies, for taking the time to come speak to us at Health Connect South.